All right, welcome everyone to a brand new explainer. Today we're diving into something incredibly high yield, especially for those of you training as radiation oncology residents. We're breaking down a landmark paper that is quite literally rewriting the playbook on a trial we all know so well, Energy RTOG 0539. For years, we've relied on clinical and histologic features to stratify meningiomas and prescribe our radiation doses, right? But today, we're going to explore how taking modern multi-omics, DNA methylation, RNA sequencing, whole exome sequencing, and applying them to this historic cohort is radically shifting our understanding of risk. And perhaps more importantly, it's totally changing how we understand radiotherapy resistance.
Okay, let's dive into this. Here is our roadmap for today's explainer. First, the RTOG 0539 baseline. Second, reclassifying risk with multi-omics. Third, drivers of RT resistance. Fourth, divergent transcriptomic signatures. Fifth, molecular groups versus WHO. And finally, clinical implications.
Section 1, the RTOG 0539 baseline, reevaluating the foundation.
To really appreciate the disruption we're about to see, we first have to ground ourselves in the original foundation of this trial. Remember, RTOG 0539 was designed well over a decade ago. At the time of enrollment, tumors were graded using the WHO 2007 criteria. That relied entirely on histopathologic features, literally just what we could see under the microscope. But as you guys know, our definition of risk has evolved incredibly fast. In 2016, brain invasion was formally incorporated into the grading criteria. Then, the major 2021 update brought in molecular alterations, specifically TERT promoter mutations, and homozygous deletions of CDKN2A/B as grade 3 defining features. And even now, we're looking at cytogenetic markers like 1p loss and 1q gain as absolutely critical prognostic tools.
So thinking back to those older 2007 criteria, RTOG 0539 stratified patients into 3 classic clinical risk arms to guide management. Low risk, which were mostly newly diagnosed grade 1s, were just observed. Intermediate risk, like newly diagnosed grade 2s post-gross total resection, received 54 gray and 30 fractions. And the high-risk group, like your grade 3s or subtotally resected grade 2s, well, they received the full 60 gray. That was our standard paradigm. But what happens when we look at these exact same patients through the lens of modern molecular profiling?
Which brings us to Section 2, reclassifying risk with multi-omics, the paradigm shift.
The data here is truly a paradigm shift. It reveals that some of the tumors we confidently placed in lower-risk buckets were actually harboring hidden, highly aggressive biology. Keep this number in your head, 7%. That is the percentage of patients in this trial who would have received completely different treatment recommendations, different clinical risk group assignments, if we applied the 2021 WHO criteria plus those newer cytogenetic markers today. A full 10% of the tumors would have been assigned a completely different grade. That is a significant chunk of your clinic fundamentally changing management based entirely on molecular data.
And the shift is absolutely fascinating to trace. When we add the 2021 criteria, and crucially, the 1p and 1q cytogenetic alterations, you see tumors literally migrating out of their original low or intermediate risk categories. We have patients who are assigned to mere observation moving into categories that would mandate 54 or even 60 gray. The molecular data reveals they were actually high risk all along.
Section 3. Drivers of RT resistance, chromosomal instability.
Now, what's really interesting about this is asking the critical question. For those patients who progressed despite receiving our 54 to 60 gray of radiation, what was actually driving their resistance? There is a striking disparity between those who responded to RT and those who didn't. When we look at isolated chromosomal losses in the non-responders, meaning the patients who progressed or died within 3 years, a massive 85% had chromosome 1p loss, compared to only 52% of responders. We see a similarly stark gap with 1,4q loss. This tells us for sure that canonical cytogenetic instability is a powerful predictor of intrinsic resistance to our standard radiotherapy.
We can actually put a number on this instability by looking at the overall copy number burden. RT responders had a median of 4 arm-level alterations per tumor. Non-responders had more than double that, a median of 8.5 copy number alterations per tumor. And what's wild is that individual point mutations, the total tumor mutational burden, didn't actually differ significantly between the groups. It is the large-scale structural instability, this heavy copy number burden, that is directly linked to RT failure.
Moving into Section 4, divergent transcriptomic pathway signatures, mechanism to bedside.
So structural DNA changes predict resistance, right? But how does that actually translate into the biology of the tumor?
For that, we look at the RNA and epigenetic level. And this mapping is so crucial for understanding why radiation fails. In the RT responders, transcriptomics and epigenetics revealed heavily active immune-related pathways, chemotaxis, cytokine signaling, driven by hypomethylated promoters. Their tumors were, in a sense, immunologically hot. But the non-responders, they showed massive upregulation of cell cycle regulatory and DNA repair pathways. Think about what we do as radiation oncologists. Our whole job is to damage DNA. If the tumor is already biologically primed with its DNA repair mechanisms in overdrive, our standard fractions of radiation are essentially bringing a knife to a gunfight.
Section 5. Molecular groups outperform WHO. The climax of the data.
We've established the mechanisms, so now we pit our traditional tools against our newest molecular classification systems. When we analyze the DNA methylation-based molecular groups, it's pretty staggering. The non-responders are heavily funneled into the hypermetabolic and specifically the proliferative molecular groups. Meanwhile, responders are enriched in the immunogenic and NF2 wild-type groups. The epigenetic signature of the tumor is practically sorting the clinical outcomes for us. So the crucial point is really captured when we run a multivariable Cox regression, looking at predictors of recurrence after radiotherapy. WHO 2021 grading, even when we add in those 1p and 1q cytogenetic modifiers, loses statistical significance. But the proliferative molecular group, it stands out with a massive hazard ratio of 5.59. It just completely dominates the model.
The authors state this so plainly. The proliferative molecular group was an independent predictor of post-RT recurrence in multivariable analysis, outperforming WHO grade. Bottom line, epigenetic classification is a stronger, way more robust predictor of how a tumor will respond to your radiation than the histology you get back from the pathologist.
Section 6. Clinical implications and future. Changing practice.
So, what do we do with all this? How does this actually change the way you will practice and the trials you're going to design? We are faced with an urgent clinical question. If a patient has a proliferative meningioma that we know is intrinsically resistant to our standard 54 or 60 gray, how do we overcome that resistance? Because we obviously can't just keep dialing up the radiation dose indefinitely.
Well, the transcriptomic data actually throws us a lifeline here. Remember those upregulated DNA repair and cell cycle pathways in the non-responders? The researchers queried compound libraries and found vorinostat. It's a histone deacetylase inhibitor, and it selectively targets and suppresses those exact pathways enriched in our RT non-responders. It's already been validated in aggressive meningioma models, which gives us a tangible, targeted drug to potentially combine with our radiation for these really high-risk patients. Let's look at how this builds into actionable takeaways for your future careers as trialists. The era of grading tumors purely by histology in clinical trials is ending. Future cooperative group trials absolutely must prioritize biomarker-driven treatment arms. You have to ensure perspective, high-quality tissue collection, and centralize the molecular analysis. Most importantly, we need trial designs that randomize radiotherapy, maybe adding radiosensitizers like vorinostat within these specific, highly defined molecular risk groups, rather than relying on those outdated clinical buckets.
It's a completely new landscape for radiation oncology. We've seen the data. We now know that a molecularly proliferative tumor is a far greater threat than a histologically high-grade one. So I'll leave you with this to ponder for your own future research. Are we finally ready to completely replace histopathologic crating with molecular profiling in our next generation of cooperative group trials? It's definitely a provocative thought, but the data is loudly pointing us there. Thanks for joining me for this explainer, and I'll see you next time.